Welcome to Community Grand Rounds. My name is Lynn Todman. I'm the Executive Director for Population Health. Before we get into the meat of our evening, I want to give you a little bit of context for why we're doing what we're doing in CGR, Community Grand Rounds. So one of my responsibilities is to conduct the Community Health Needs Assessment. And in collecting the data, we identified some significant health inequities in Berrien County and Lakeland service area. So here's a map that shows the distribution of life expectancy across census tracts in Berrien County. This tells us Berrien County has a life expectancy that's shorter than the Michigan average and the US average. And that circle there, the darker the color green, the lower the life expectancy, and you can see there's a high concentration of low life expectancy tracts in and around the city of Benton Harbor, and to a lesser extent around Niles. Doing a deeper dive, what we learned is there's a 19-year life expectancy gap in our service area. The lowest life expectancy is in Benton Heights. Those of you who are from around here know that's not far from the city of Benton Harbor, and the highest is in Berrien Springs, which is where we are right now. It's notable that the two of the largest cities, St. Joe and Benton Harbor, who are separated by 2 miles, have a 14-year life expectancy gap. And of the 5 tracts with the lowest life expectancy, all of them are in and around Benton Harbor. And 60% of those tracts are majority African American. We also have data on death rates. Again, the darker areas are those areas where people die at really high rates. And in fact, the highest death rate in our county is more than 3 times the size of the lowest death rate. You can see in and around the city of Benton Harbor, again, the death rates are high, and then there's a census tract in Niles too, where people die at really high rates. Doing a deeper dive still, we learned through some analysis that 68% of African Americans in Berrien County live in a high death rate census tract. And again, if you look at those tracts with the highest age-adjusted mortality, most of them are in and around the city of Benton Harbor. There is the city of Niles in there. And the death rate, those areas with the lowest death rates, those tracts, 100% of them are majority white. So it was hard to ignore the fact that we have these disparities along racial lines. And as disturbing as that information is, the next slide, what we find is, this is a little bit hard to read, but essentially what it says is that the disparity, the black-white disparity in death has actually grown since 2007 in most age categories. It has narrowed for people under the age of 1, so we've been pretty effective in reducing the infant mortality rate. But the trends are going in the wrong direction. So that's the context for this work, that we have to actually acknowledge the fact that there's certain populations that are suffering in this community. And you will know after the presentation, if you don't already know, there's only so much the health system can do to address those, that we have to start working outside the walls of the health system and address some of the social factors that are impacting these life expectancy and death rates. We have to start thinking about what we do with respect to housing and education and transportation and social connectedness and cohesion. All these things matter in shaping health. And that's what Dr. Bechara Choucair is going to talk to us about. So, without any further ado, let's go to the next slide. So, Dr. Choucair, I think many of you have read about him. He's the Senior Vice President, Chief Community Health Officer for Kaiser Foundation, Health Plan, and Hospitals. He was the Commissioner for Public Health in the city of Chicago. He was at Trinity, and then I knew him as the poverty medicine doctor at Heartland Alliance, where I was on the board. So I think I've known of his work for at least a decade. I'm really excited that he's here. I'm proud that he's here. He flew all the way from Southern California to be here. Bechara, as he likes to be called, Bechara, please come to the stage.
All right. Thank you. All right. Good evening, everybody, and thank you so much for taking an hour and a half of your evening here to come in and engage in this conversation. I think many of you know Lynn. I've worked and known of Lynn for years. First, really, as a practicing physician at Heartland Alliance, doing a lot of work around poverty medicine, and Lynn was on the board of directors of Heartland Alliance, and then she ended up being the board chair, and I got to work with her through my tenure as health commissioner. So for those of you who know Lynn, when you get an invitation to come and speak at an event that Lynn asks you to do, you will absolutely come up and do that event. So thank you, Lynn, for inviting me to join here tonight. I do have roots here in this area. I have a small second home that was in Sawyer, Michigan, that I used to come in and enjoy lots of time in Sawyer. So it was great to be back here. I got a chance to stop by on my way here to enjoy it. All right. So today's objectives are really about how do we identify unmet social needs of people, and how do we meet those social needs. So I'm going to give you some concrete examples of how we're doing that at Kaiser Permanente. I'm also going to talk a little bit about what is our role in creating social change and creating social health change at scale, and what health systems can do to make that happen. And I'll be able to also reference some examples there. And then I'll give you some really kind of concrete differences between what's different between a community health approach to population health improvement, between what we can do in the community and what we can do as health systems. So those are really today's objectives. But before I start there, a little bit more about me personally. So I was born and raised in Lebanon, and I grew up in the midst of a civil war, and I was the first person in my family to actually go to medical school. And I don't know about you here, but my mom would brag about this to everybody who would listen. And she'll be at whatever conversation, she'd always want to talk about her son who's becoming a doctor. And she almost got so comfortable that she felt she could even start prescribing some medications there. So when I immigrated to the United States, now she was bragging even more. She's like, her son is so good that he's treating now people in Texas as a practicing physician. So fast forward a few years, and I ended up leading the health department in Chicago, the third largest city in the country. I was so excited to be in that role. And honestly, not in a million years as I was growing up, I would have thought that I'll land in Chicago government running one of the largest public health departments in the country. And as you know, when you start in public health, you always talk about the importance of changing policies, systems, and environments so that people can have the opportunity to live the lives that they'd want to live. So early on during my tenure there, I was being prepped for a TV interview about my role as the health commissioner for the city. And of course, our media team was like, you really have to hit home the message of policy, systems, environmental changes. So I prepared for the interview, and I got a chance to be on ABC7. And during that interview, I probably mentioned policy, systems, environmental changes probably like 7 times in my 7-minute interviews. So the following day, the interview was on YouTube, send it to my mother. No word whatsoever. This is the mother who brags about her son constantly. So I picked up the phone. I'm like, Mom, did you see the video that I sent you, my interview on ABC? This is like a leading TV station. And she's like, yeah, I saw it. And it looked good. Your haircut looked good. Your tie was good. I'm like, Mom's like, what about the content? Yeah. And I remember she waited for a few seconds, and here she's like, you kept saying policy, systems, environmental changes so many times. What happened to you being a real doctor? Why are you really focusing on these things now? And it took me a few years to be able to really better be able to articulate why this type of work is so critical for the health and well-being of communities at scale. And as a physician, I was able to spend a lot of time with my patients and work with them and spend time with them and help them develop goals that are important to them to be able to thrive and live the lives that they'd want to be. But I felt like it was always downstream. And there were a lot of things that we can do more upstream that would help us change those environments, change those policies, change those systems, so that we're not having to deal with those issues downstream, but really create the right place for people to live the lives that they'd want to live. And to be able to come in and be part of an organization at Kaiser Permanente where I can do that at scale in the communities where we're at is truly a humbling experience. So a little bit about Kaiser Permanente. I think many of you here are familiar with our system. We are the largest integrated health system in the country. Every day, 12.4 million people trust our top-notch docs and physicians with matters of health, life, and death. And that's a big honor and big responsibility. We have a network of about 23,000 physicians, 58,000 nurses, over 200,000 employees, and we're in multiple states and cities and counties providing care and coverage to those 12.4 million people. And our mission has been exactly the same since we were born 75 years ago. And it's about improving the health and well-being of our members and improving the health and well-being of our communities. And we truly believe that those actually go hand in hand. Because if you think about it, there is no way we're going to be able to improve the health and well-being of our communities if we don't do a really good job at delivering top-notch care to our 12.4 million members. But make no mistake, there is no way we're going to be able to optimize the health and well-being of our 12.4 million members if we don't do a really good job at improving the conditions for health and equity in the communities where those members live. And when we do that, when we focus on improving conditions for health and equity, not only our members would benefit, but really all 68 million people who live in our communities would be able to benefit. And that's what our community health work is all about. Because as an organization, we truly believe what we do within the four walls of our hospitals and medical office buildings impacts probably 10 to 20% of the health of our members. What truly impacts the health and well-being of our members is what happens in the communities where they live and play and learn and work. So because we are an organization that's all about health, we have to be focusing on those communities, and we have to be focusing on optimizing those conditions so that our members live healthier lives. And that's what this first part of the presentation is about. So I'm going to discuss two really big buckets of work that we do. One, what is it that we're doing for our own members when it comes to their social health? For our own members. I'm going to give you concrete examples of some of the work that we're doing there. And then the second part of the work is, the second part of the presentation is, what is it that we're doing in the communities that are critical, that we truly believe is critical to improving the conditions for health so that our members and our members-to-be are having healthier lives. So that's the two parts of the discussion that I'm going to be leading today. And then we'll have plenty of time for Q&A towards the end. So let me start by what we're doing for our own members. And there's this quote from our chairman and CEO, Bernard J. Tyson, where he just said, many of our members are basically asking themselves the question, do I buy milk or do I get my medication? And those social needs are real for our members and for people in our communities. The reality is, when you think about how much we invest in health in this country, we invest in health in multiple ways, but we invest in health care, and we also invest in social health. When you look at the total sum of what we're investing, it's comparable to what other people in other developed countries are investing. But when you look at healthcare particularly, we invest a lot more in healthcare than any other developed country in the world. But yet, our life expectancy, our healthcare outcomes are lower than most of these countries that invest far less than us in healthcare. But what's different in those other countries is that they invest more in social health than we do. They invest more in the social services sector and the social services infrastructure in those communities than we do. And that, I think, is critical because we know that what impacts health happens out in the communities where those members, where people live and play and learn. Just recently, actually, a couple of months ago, we commissioned a survey of Americans, a representative sample of people living in this country across all the country, across all different socioeconomic classes, and we asked about social needs. We particularly focused on those social needs that are directly tied to health. We focused on housing stability, food insecurity, transportation, economic stability, and social isolation. And when we asked Americans what we've learned from that survey is that 68% of people living in this country have had at least one unmet social need this past year. 68%. And out of those who have unmet social needs, 25% of them, 1 in 4, have had that unmet social need was a barrier to health. Those are the folks who had to make a choice between buying milk or getting their medications. They had to make a choice between paying rent or coming to see their doctors and paying their copay. 25%, 1 in 4 Americans. We've also learned that for those people who have unmet social needs, they're twice more likely to rank their healthcare as their health and well-being as poor or fair. Twice as likely. And what we thought was really telling is that 97% of those who responded to that survey said they wanted their medical providers to ask them about their social needs during their care visits. 97%. So for us, that was really significant. 80% of folks they thought it would be helpful if their care delivery helped them navigate their social needs space. And for us, the way we're responding to this is by launching what we call Thrive Local. And we just launched that effort a few months ago, actually a couple of months ago. And what we're doing through Thrive Local is now we're building networks in each one of our service areas that would include social services providers who are available to support our members' social needs. So think about that for a moment. 75 years ago, when Kaiser Permanente was created, we started developing networks of primary care docs and specialists to support the physical health of our members. Then we started developing networks of mental health providers to support the mental health of our members. And now, in this very pivotal moment, we as an organization are saying we're going to also start developing networks to meet the social health of our members. A huge pivotal moment for an organization like ours. And we're committing to do that at scale. So over the last decade or so, we had over 35 different programs that were trying to meet the social needs of our members. And they vary in scale, in comprehensiveness. They vary in all different shapes and forms. And now what we're saying is every one of our service area, the 39 of them across the country, we're going to develop a network of social services providers who are going to be linked to our doctors and nurses through a dual interface with our electronic health record system, so that when our doctors, nurses, or social workers refer our members to an entity in that social network, in that care provider network, we'll be able to do that seamlessly through our electronic health records. And all of a sudden, now our electronic health records include the medical record, the physical health record, the mental health record, and the social health records of our members. And we're so excited about this effort. We're launching the first site is going to be in Portland, Oregon, and I got a chance to go and spend some time with our team there and to see the energy and the excitement around this work from our members, from our community partners, from our physicians, from our nurses is just so exciting, and I can't wait to have our very first referral happening. And over the next 2 years, seeing those networks being built all the way from Long Beach, California, all the way to Baltimore, Maryland, and I'm so excited about this work. So that's an example of the type of work that we're doing at scale to supporting our members, individual members' social needs. I'm going to shift gear and talk a little bit about some of the examples of some of the work that we're doing in the community to help change those policy systems and environmental changes that are needed so that we can create better environments for our members and people in our communities can live healthier lives. And what I'm going to do is I'm going to talk about 4 concrete examples. I'm going to reference our work around housing and health. I'm going to talk a little bit about our work in schools. I'm going to touch a little bit about our work on environmental stewardship and some of the work that we're doing in the community. And then we'll spend some time taking some questions at the end. So I'm going to start with housing and health, and why this work is so important. When you ask people in this country, 89% of people will tell you that having safe and stable housing is very or extremely important to overall health. And I'm assuming we all agree about this issue. So think about it for a moment. So if you look at the rent, the median gross rent over the last 20 years or so, we've seen an increase by about 10.7% across the country. This is an average. You look at the median household income, you actually see it's flat over the last 19 years or 20 years. So what does that mean? When your rent go up and your income stay flat, you're forced to go into a lower standard, substandard housing. That means you're going to different neighborhoods, you're getting into places that might have mold, might have lead paint, might not have the best conditions for health. And what we've seen is that the unsafe and unstable housing or unhealthy housing has cost the United States health system billions of dollars when it comes to asthma, lead poisoning, unintentional injuries, and we know that we are facing a housing crisis in this country. Now, where most of our operations are at Kaiser Permanente, we're in LA, San Diego, San Francisco, Denver, Washington, D.C., Seattle, Portland. All of those are the hubs of really where we're facing the housing crisis. And that has really spurred or fueled an issue with homelessness. And most of our communities, homelessness is on the rise. And that's a significant issue for us for all kind of different reasons. But even if you think about the healthcare reasons, somebody who's homeless, their life expectancy is on average 27 years less than those of us who are housed. Think about that for a moment. 27 years less than those who are housed. We know that people who are experiencing homelessness have increased risk of having many communicable diseases, some of the chronic conditions, and we know that if you're homeless and you're admitted to the hospital, your average length of stay is 2 to 3 days longer than if you're not homeless. We also know that if you're homeless and you were in the hospital and you got discharged, your chances of being readmitted is 50% higher. So homelessness and health, housing and health are so interconnected. As an organization, we have to be engaged in ways that would address those significant issues, particularly in the communities where we're at. You know, this slide shows some numbers from LA where they've seen 76% increase in deaths among people who are on the street this past 5 years. Just last year alone, 918 people in LA died on the streets. So we truly feel the responsibility to partnering with the right community partners to be able to make a difference when it comes to this issue. So what is it that we're doing? So we're doing a bunch of different things, and I'm going to give you some specific examples of some of this work. We're doing work to really try to end chronic and veteran homelessness in our communities. We're doing some work around investing in expanding and preserving affordable housing in our communities. We're doing some work around policy in our communities. I'll give you some of those examples. I'm actually going to start by talking about our policy work, because it's so critical for us if we're going to be serious about advancing community health. We have to be serious about leveraging a huge tool in our toolbox that have a humongous impact, and that's policy. And that's what we're doing around housing and health. And we're doing that at a local level, state level, and federal level. So at a local level, what we've done last year is we've partnered with the De Beaumont Foundation, and we've launched an effort that we call City Health. City Health has identified 9 evidence-based policies that if we work with local government to adopt those policies, we know that the health in that community is going to be improved. Those are evidence-based, bipartisan policies that any city could really roll up their sleeves and make it happen. One of those policies that we've agreed upon in the City Health agenda is inclusionary zoning. And now we're working with local government to making sure that inclusionary zoning is an integral part of the housing policies for those cities where we're at. At a state level, we identify particular policy bills, particular strategies, and state by state, we advocate for those policies with the right community partners to make a difference. Last year, for example, in California, we were supportive of a couple of those efforts to increase the funding for veteran housing and for housing for people with mental illness. And then at a federal level, we are the national partner to a coalition called U.S. Mayors and CEOs for U.S. housing investment. This is a coalition of 24 bipartisan mayors from across the country who came together with CEOs in their communities saying the federal government has a role to play to be able to make a difference when it comes to the policies that the federal government could have around housing. And we are the national partner to that effort where we're lifting up our voices at a national level and making sure that the government, the federal government, is having the right investments when it comes to housing. So policy is a huge, important tool in your toolbox that you can use effectively to be able to make a difference on a really hard, tough issue like housing. And then we said, well, what else can we do to increase the supply, either by preserving or expanding affordable housing in our communities? We're not community developers. We're not housing organizations. So we needed to figure out a way to partner with the right groups in our communities to do just that. At the same time, our Treasury Department invests money in the market so that we can have financial return on investment on those dollars, so we can continue to be able to lower our premium, advance our affordability agenda to our members. And we said, would it be possible to work with our Treasury Department, dedicate some money from our Treasury, and instead of investing in the market, let's invest in projects that would still give us some financial return on investment, but most importantly, let's think about projects that would give us social return on investment. And our board and our Treasury Department were super excited to work with us. And now we've dedicated $200 million out of our Treasury that we're investing particularly in an area to preserve and expand affordable housing in our communities. We don't know how to do that. So we've partnered with a couple of the leading community development finance institutions, CDFIs, for the community developers here in the room, or the finance people. You're probably familiar with what a CDFI is. And we're working with Enterprise, which is one of the most respected CDFI in the country. And we created 2 funds. One that's making loans available at a low return, and those are available everywhere across our communities, all Kaiser Permanente communities, $100 million to support preserving and expanding affordable housing in our communities. And we created another fund that we're calling it the equity. It's an equity fund that's actually identifying buildings that are right now affordable, but they're at risk of losing their affordability and we work with community developers, not-for-profit community developers, we get equity in those buildings, and in return, we'd want to preserve their affordability for the next bunch of years. And we are so excited about this work. We actually closed on a first multi-unit building in East Oakland a few months back. And that building was getting ready to lose its affordability, and we went to start talking to people who were living in that development. The very first person we talked to ended up being a Kaiser Permanente member, and what she told us, that she's got multiple medical problems, diabetes, high blood pressure, all of that. She's taking multiple medication, and what she said, if her rent would have gone up by $100, she wouldn't have been able to afford it, and she would have had to be on the street. So these types of, and this is an investment that's going to still give us some financial return on investment, but most importantly is giving us the social return on investment in our communities. We have probably about 20 of these projects in the pipelines right now, and as these are closing, we're getting ready to discuss those and share them publicly. One other example I want to do that I thought is a really cool way that we've leveraged what Kaiser Permanente does in working with the community around finding people who are out on the streets who are having multiple chronic medical problems. So in Oakland, through a project we worked on last year, we got to know the 515 people who are 50 plus, who have at least one chronic medical conditions, and who are homeless. And we got to know them by name. So we've literally, with the community partners, developed a by name list of the 515 people who are homeless in Oakland, who are 50 plus, who have one or more chronic medical conditions. And for those of you who are fairly close to the homelessness issue, 50 is really the new 75 when you're homeless. And the reality is those folks are struggling with a lot of medical problems. And now that we've known them by name, we challenged ourselves and our community partners, and we said, what would it take to get every one of those 515 people off the streets into housing? And when we started talking to people about that, everybody was like, please fail fast. Great, you can do that. It's not going to work. And we challenged ourselves and we challenged our partners. We said, what would it take? It's 515 people. We know them by name. We know where they are. We know each of them's conditions. So what would it take to get these people housed? We started this effort in February of 2019. And today in July, 315 people are off the streets in stable housing with permanent leases, long-term leases, living off the streets of Oakland. And that's the type of challenge that I think we're so excited to be able to take on as an organization. So a lot of work in the homelessness and housing space. I want to shift gear and just spend some time talking about our work in schools. And this is so critical because the interconnection between education and health is so critical, so important. So we truly believe that our commitment to schools is an integral part of our health agenda as an organization. So over the last 10 years or so, we've launched an effort that we call Thriving Schools, and we are right now in over 750 schools in our communities, working with students, teachers, administrators, on all kind of different things, from healthy eating and active living, all the way to mental health and building resiliency. And we're very proud and excited about this work. So over the last 10 years, we've interfaced with those schools where over 500,000 students have been, 24,000 plus teachers and administrators, and we've seen over 4,000 changes when it comes to healthy eating and active living that have happened in those schools to really promote health and well-being in the schools. And we continue to grow this program. But what we've learned throughout the way in our work in school, that healthy eating and active living was important, but critically as important was the need to support building resiliency and making sure that we're addressing the mental health and wellness issues that students and teachers and parents are facing. We heard it constantly in every one of our schools' work. And if you think about it, people in this country or kids in this country have been exposed to a tremendous amount of adverse childhood events. We actually, as an organization, together with the CDC, did the very original research about ACEs, or adverse childhood events. These kids get exposed to all kind of events from things related to violence, whether it's psychological violence, physical violence. Things come from families that are dealing with substance use, all kind of different issues. In this country, and what we've learned from that research is the more you're exposed to more ACEs, the more likely your health outcomes are going to be bad. And we've known that. We've known that for decades. And then what we also know is that in this country, probably 35 million kids have been exposed to at least one of these ACEs. And about 13% or so have been exposed to 4 or more of these ACEs. And we know the direct link between exposure to these events and your health outcomes down the line. But we didn't know what to do. So over the last year and a half, we've been working with people who've been studying this and doing interventions at a smaller level and trying to design an intervention that we can take to scale. And we're really excited to launch RISE, which is our effort, our interventions that's going to be starting with 200 schools within our footprints who are going to be doing these interventions that would help the students, the teachers, the parents, the administrators in dealing with these issues and making sure that people have access to behavioral health services if they need to. But also focusing on the policy change within those schools to create the right environments for kids and teachers to be able to thrive. I'm really, really excited about this work. There's not a lot of evidence that's been built over the last couple of decades, and we're hoping that as we implement this intervention, we'll be able to build on the learning, build on the capacity, and be able to share some of the successes and some of the failures that we're going to see in this work. So I'm going to shift gear to 2 more things. One, I'm going to be talking about the economic work that we do in our communities and why this is so critical for health. And then I'll end with our work on environmental stewardship, and then we'll open it up for questions. So economic opportunity, why this is so important. Because if you don't have a good paying job, you're not going to be able to live the life that you'd want to live. And you won't be able to likely access the care that you'd want to access. And as an organization, we think of ourselves in our communities as anchor institutions. We're not there to just provide healthcare services. We absolutely do that, and we do a really good job at it. But we also hire people, we build facilities, we invest in the market, we do all kind of things that would really bring economic vitality to our communities. And a few years back, we started asking ourselves, what would it take for us when we're building a new facility to think about not just that facility and how fast and how cheap we can build it, but also think about what is the community implications of that facility and what would it look like to leverage those dollars in a way that would lift that community up. So we started thinking about our procurement policies. We started thinking about our Treasury Department. We started thinking about our hiring policies. We started thinking about our national facilities services. And we said along each one of these steps, every time we're spending $1 in our community, we want to make sure that we're getting not just the financial return on that dollar, but also spend it in a way that would lift up community health. So I'm going to give you a couple of examples, particularly around our commitment to supplier diversity. And back in 2014, we got to the goal that we've set for us on $1 billion in investment in supplier diversity. $1 billion, and we were the first health organization to join the $1 billion roundtable. And since then, we've actually doubled down on our commitment to purchasing from minority, women, and veteran-owned businesses. And this past year, we've had $1.9 billion of our purchases went to to diverse suppliers. And some of our main suppliers actually were able to go by themselves and get another $400+ million committed to supplier diversity. And that's from 2014 to 2018, from $1 billion to $1.9 billion. That's the type of commitment that we think is truly relevant to lifting up community health. And we've also realized that small businesses in our communities can be a great asset to economic vitality in that community, to jobs in that community. It's important for those businesses to be able to grow, and it's important for us to be able to do business with them. So over the last 6 years or so, we invested and partnered with an organization that's helping bringing those small businesses in our footprint and work with them through a tuition-free type of process to help them grow so that they can be able to draw down on capital, hire more people, and be able to do business with an organization like Kaiser Permanente. So we've had 7 cohorts so far. I actually, right before coming here, I got a chance to go and spend some time with our cohort in Sacramento and Stockton, California. They have one cohort with 85 businesses. I got a chance to talk to some of these small businesses. We had over 580 of those businesses over the last 7 years work with us, created hundreds of jobs, draw down on lots of capital to be able to grow their businesses and be able to do business with Kaiser Permanente. So I would encourage you to think through your role as an anchor institution and how you can play a significant role in that space. This is such an important role that health systems could play that a few years back, actually when I was still at Trinity Health, I got a chance to connect with the folks at Kaiser Permanente, the folks at Dignity Health, and we brought those 3 systems together, and we've invited other health systems to create the healthcare anchor network that really support health systems in that journey. And now there's almost 37 or so health systems from across the country in that network. All right. So the last part of the presentation, before we open it up for Q&A, how are we doing on time? All right, is really about our environmental stewardship work. And we know that climate impacts health. The science is very clear there. And we know that we have a role as a system to make sure that we're addressing environmental issues, and we do set environmental stewardship goals for our organization. So we set very ambitious goals. So over the last few years, we've developed a climate action. We've set a climate action goal. We have goals around sustainable food. We have goals around waste reduction. We have goals around water conservation, goals around sustainability, safer products. And we've been very vocal about the importance of us as an organization to think about these issues. We wanted to make sure that we're using clean power. So over the last year, we've been shifting our use of power to clean power, and we've made a commitment that we will be carbon neutral in 2020. Think about that for a moment. In 2020, that's right around the corner, and we're on our way to become carbon neutral in 2020. And that's so important for us because it helps us think about the broader perspective that an organization like ours, an $80+ billion organization, can have an impact on the world in a way that we think would be helpful to health as well. When you look at our carbon emission, since 2008, even though we grew significantly since 2008 by more than 30+%, we've seen a reduction in our carbon emission by 30%. So we grew by over 30%. We've seen a reduction in our carbon emission by 30%. We're also very serious about conserving water, and we've set a target that we'd want to reduce our water utilization by 25% per square foot by 2025, and we're halfway through that. And this is one of my favorite. We're really avoiding tailpipe emissions. last year, we filled over 24 million prescriptions by mail. Think about all the cars that didn't have to drive for our members. 24 million prescriptions. Those are all the people who are going to drive from their home to the pharmacy to pick up their prescription. Now their prescription is at home. So we're really excited about our work. So I'm going to stop here. I hope I gave you a good perspective of what is it that we're doing to advance community health when it comes to our members by focusing on their social health. And then what is it that we're doing in the communities overall to create better conditions, and the examples I shared with you about our work on housing, our work in schools, our work on economic opportunities, and our work on the environmental stewardship. And with that, I'm hoping we've got lots of questions. Make sure you enter your questions, and Lynn, come back.
Thank you very much.
All right.
Thank you. So we have a lot of questions about inclusionary zoning. What is it, and how does that impact housing availability or affordability?
Yeah, inclusionary zoning is such an important policy that local government actually in most places have the ability to control, and that would give guidance on making sure that there is preserving a certain percentage of the new construction to be able to support low-income housing and other types of housing. And that's an important policy that we think is critical that local government could take and really can support that housing agenda.
Okay, thank you. Then someone has asked, was there a pivotal event that led you to community health, a piece of research? What was your point if no looking back? I'm not sure what the end of that question was about, but was there a pivotal event or experience?
So there were many pivotal moments. There's, it starts with what we've learned from research, but to me it was mostly a real important moment with one of my patients. So I think over the last few years, we're starting to realize that really what impacts health does not necessarily just happen in the four walls of your health systems. It happens out in the community. And as we started seeing more and more of this research, I'm starting to get more and more convinced that this is where I can really be able to contribute and be able to have a better impact. But the true pivotal moment is a patient of mine. I was a practicing family physician in Rockford, Illinois, running the Healthcare for the Homeless program. And I had this one patient of mine, Judy. She was in her mid-30s. She was a fantastic person, vibrant personality. She's always smiling, always have something to say. And at the same time, she struggled with substance use issues. She had mental illness. She was dealing with bipolar disorder. And she was homeless. And she's literally slept in the parks or sometimes in shelters for most of the nights. And she was my patient for many years, and I remember this one night where we were having a conversation, and she said, stop talking to me about all these medications. What I'm worried about is where I'm going to be able to sleep this winter when it's going to be freezing cold. And she said, I really worry that I might end up dying in the parks. And so we knew every time that I would see Judy, that would be in the back of my mind. And you can imagine the day I've heard that somebody was found dead due to hypothermia in the park and ended up being Judy. And I felt like I failed her. I felt like our systems have failed her, our policies have failed her. And I figured that I should be able to do better for the Judy, for her memory, and for the Judys of the world.
Pivotal moment. How did you receive buy-in of the community lawmakers and leadership at the hospital for this work?
I have to tell you, the commitment starts within the organization, and it starts from the people of Kaiser Permanente who are truly committed to this work. And this is not just the people who work within the community health teams across the country, it's people across the organization. Every time we launch an effort, there's outpouring support from our colleagues across the system, but it also is all the way to the top. Our board of directors is extremely committed. We have a community health committee of the board of directors that's been active for 15 years, I think, or so. Dr. Cynthia Tejas is the chair of that committee, very active committee. There's a big commitment from our chairman and CEO, Bernard J. Tyson, the rest of the executive team, and people in the community when we show up, and we show up with humility to the community. We don't go to the community and saying, here's what we think you should do. We go there, we're actively listening, we're consulting with the community, we're learning from the community, we're co-designing with the community, and we hope we bring what we have, what we're best at, but also we're there to learn the most and be able to create the right interventions that would make a difference. And that's, I think, is really the key for success of these types of community events.
What do you mean by co-design?
It's easy. I'm a family physician. Yeah, I'm a physician. I went to medical school. It's easy for me to learn of a study, read a study, see how the design of that intervention is done, and just say we're going to take that same exact design and plug it in this place. It just doesn't work like that. And I think that's really the arts and sciences of working with the community, is how do you learn how to do that? You have to be in active listening, deep engagement. And it's hard. It takes more time. It's frustrating. But I think the product will be a lot better than saying, here's an intervention and let's just
do it,
plug it in.
Right. I think we'll take more questions, but if you could put the slide back on so people who didn't have a chance to. So let's see. How do you partner with health departments?
Oh, health department. Well, I'm the product of a health department.
Right.
So we are constantly trying to figure out how we can add value to health departments, how we can learn from health departments, and we have different ways that we're engaging with health departments. I actually spend some of my time with health officers. Each of our community health leaders in each one of our service areas have good, solid working relationships with the health department. Some are better than others, but I think the intersection between public health and healthcare is so critical to be able to lift up communities, improve health outcomes, improve health and well-being in the communities. And if we stayed siloed, no one entity could answer that, could make a big difference. We really have to learn how to work together. And we speak different languages.
Right.
And I had the opportunity to live in both places, and it's hard. I mean, just the concept of population health, the difference between population health and community health as a health department and a health system is a huge difference. I had to learn what that is when I joined Trinity Health first and then now at Kaiser Permanente, and really finding the common language is critical to making a difference there.
To what extent do you believe it was important to know the name of frail homeless persons in your effort to direct investment and partner engagement?
I can't tell you how important that process was to get to the point where we knew people by name. We're a data-driven organization, and, in a heartbeat, I can tell you exactly who are the members who don't have their blood pressure well controlled, or who are the people who need to be on ACE inhibitors, but they're not taking ACE inhibitors. Who are the people we need to check on their cholesterol, but they haven't had it checked. And we can create interventions to make a difference there. But in the social services space, we have ways to go when it comes to using data. So our approach around and that's, I think, what we were able to bring the most to the table when we got with our community partners. We had to learn a lot from our community partners on how to work with people who are 50 plus, who are homeless. But one thing that I was most excited about is the ability to get to that by name list. Because when you say, we have 515 people who are homeless, and we need $5 million to support the work on homelessness. And then we'll do a count 2 years down the line. We'll see how that count was shifted. Maybe it's okay. It's good, important work that needs to be done. But when you say, here are the 515 people by name, we know their faces, we know their stories, and our commitment is to get them off the street into stable housing and then you see them in stable housing, it changes the conversation completely.
Who's we? We know them, you said. Who's the we who knows
So
them?
we partnered with community-based organizations who are out on the streets, who are a lot more culturally trained and appropriate to doing outreach to people who are experiencing homelessness. And these are, the organization we work with is called BACS, or the Bay Area Community Services. And they have the people on the ground, in the shelters, on the streets, in tent cities, engaging these individuals,
So that's how
and
they
really
know.
try to get them housed.
Okay. What do you say to physicians who are afraid to open Pandora's box and ask those social needs questions?
Look, this is a very real question. I don't know who asked it, but this was, I practiced in a community health setting in a federally qualified health center for 12, 15 years of my clinical career. And if I didn't know what to do for that patient, it's hard for me to ask the question. Because if I ask you if you're at risk of losing your home and I have no resource to support you, I don't know if I'd want to ask the question.
Right.
And I think that's part of why the Thrive Local effort is so critical, because now when our doctors, our nurses, our social workers are asking those questions, they know exactly who to refer to, and they're going to do it right from their electronic health record system. It's not log in, log out, log into the internet, do Google search, find the phone number, give the phone number to the person. It's just and we're planning to be able to make that service available to members as a self-referral, because some people are not comfortable coming and talking to their doctors or nurses about their food insecurity, or maybe they're ashamed of it, or they don't want to talk about it. But if from the privacy of my own home, I can go through my KP app and be able to find a resource and connect to that the same way I connect with my doctor, that's a great way for us to be able to do that.
Great. Let's see. What infrastructures do we need in order to implement these changes to make a visible impact on our local area in a more practical way? So what are the infrastructures do we need in order to make these changes?
I think the most important thing is you need the will.
Okay.
And the will is probably 80% of the way to get you there. Because once you have the commitment, then resources will follow. That's, I think, is critical. Right. The other piece is you have to be able to invest in the community, understand your community, know the people. I'm loving the fact that you do a community grand round that's open to the community, where people can come in and lift up their issues, talk about their issues. And so your active engagement in your community health needs assessment, building that trust is so critical for you to be able to have any success.
Okay. Let's see. We have lots of questions here.
All right.
What type? Let's see.
The last one will be an easier question or a tough question.
I'm just trying to keep scrolling. Can we get a copy of your slides? I think the answer is yes to that. What type? I think you alluded a little bit to this, the type of community partners you engage with. So I think you alluded to that.
let me add just one more.
Sure.
I always challenged myself and challenged my team to think of non-conventional partners.
Oh, yes, you told us some interesting ones.
Yeah, it's easy for us to think about when we are doing our community health needs assessment. We always go to the diabetes people, to the smoking people, to the obesity people. I would challenge us to think about non-traditional partners. And that, I think, is so critical. And I remember my days in the health department in Chicago, where I started going to the hackathon nights. I had no idea what a hackathon
Tell people what
is.
hackathon is.
Right. I had no idea what a hackathon was back in 2009.
Right.
But I would always encourage us to think about these non-traditional partners who are excited, wanting to make a difference, and let's think differently and out of the box.
Talk a little bit about the artists. When you started at Kaiser Permanente, who was in your department?
Yeah. So, it was in one of the slides, and I didn't get a chance to talk a little bit more about it. So as part of our commitment to working in schools, we have a whole educational theater program. And we literally have artists in every one of our regions who create plays around health issues that matters to that community, and they go show the play, 40 minutes, 45 minutes, and then it's followed by sometimes an hour, sometimes 2-hour discussions to lifting up issues like mental health stigma, like building resiliency, things that are tied to a lot of the challenges that youth are seeing. And I have to admit, when I first joined Kaiser Permanente, I'm like, artists, theater plays and all of that, and now I'm a big fan of this program.
How many artists?
We probably have, between all the different regions, probably about 100.
100 artists in community health.
Yeah.
Okay.